First manual muscle test is scapular retraction and downward rotation. The patient lies prone. The arm being tested is behind the patient's back with the humerus internally rotated. Stabilization is at the trunk, and palpation is lateral to vertebral border of the scapula. Resistance is the lateral scapula as the patient attempts to lift the hand off the back in an upward lateral direction. Resistance is being placed, and this tests the primary movers of the rhomboid major and the rhomboid minor, and the secondary movers of the middle trapezius. We are manual muscle testing scapular retraction. Patient lies prone, and the elbow is extended, and the humerus is flexed to 90 degrees off the table. Stabilization is at the patient's trunk, and palpation is between the spine and scapula and the spinous process. Resistance is at the scapula as the patient tries to retract the scapula. Primary movers are the middle trapezius and the rhomboids, and secondary movers are the upper and lower trap. We are manual muscle testing scapular protraction and upward rotation. Patient lies supine, and the test arm is flexed to 90 degrees. Stabilization is at the trunk, and resistance is placed at distal humerus, proximal to the elbow, and you instruct the patient to punch the ceiling. Protraction occurs while you resist. Primary movers are the serratus anterior, pectoralis minor, and trapezius. We are manually muscle testing scapular depression and retraction. Patient is lying prone. Starting position, the arm is being tested as abducted to 135 degrees with the forearm supinated and the patient's head rotated to the side opposite being tested. Stabilization is at the trunk, and palpation is medial to inferior angle of the scapula being tested. Resistance is placed at the scapula, and you instruct the patient to raise their arm. So go ahead and raise your arm. Primary mover is the lower trap, secondary mover is the middle trap. We are manually muscle testing scapular elevation. The patient is seated, and the starting position is seated. Stabilization of the patient is at the trunk. Palpation is the supromedial to scapula. Resistance is placed at the superior aspect of the shoulder, and the patient assumes a shoulder shrug position. Primary movers, the upper trap and the levator scapulae. This test is called the empty can or supraspinatus test. Subject stands with both shoulders abducted to 90 degrees and then adducted to 30. Internally rotated so the subject's thumbs face the floor. The examiner then resists the subject's attempt to actively forward elevate both shoulders. Positive finding is involvement of the supraspinatus muscle and or tendon is suspected with noted weakness and a report of pain. This is the Yergeson test. Subject sits with the elbow flexed to 90 degrees and stabilized against the thorax. Forearm is pronated position. The examiner places one hand along the shoulders of the subject's forearm and the other hand along the proximal portion of the subject's humerus. Near the bicipital groove, the examiner resists the subject's attempt to actively supinate the forearm and externally rotate the humerus. Pain that is reported to exist in the area of the bicipital groove is a positive finding and may indicate biceps tendonitis. This is the Gerber liftoff test for subscapularis pathology. Patient is standing with the humerus internally rotated and the dorsal surface of the hand placed against the mid-lumbar spine. The position of the examiner is standing behind the patient, and the patient attempts to actively lift the hand off the spine while the humerus stays in extension. Inability to lift the hand off the back implicates positive findings that are associated with tears or weakness of the subscapularis muscle. This is the active compression or the O'Brien's test. Patient is standing. The GH joint is flexed to 90 degrees and horizontally adducted to 15 degrees from the sagittal plane. The humerus is in full internal rotation, elbow extended, and the forearm pronated. The examiner is in front of the patient, and one hand is placed in the superior aspect of the patient's distal forearm. Patient isometrically resists the examiner's downward force, and the test is then repeated with the humerus externally rotated and the forearm supinated. Pain that is experienced with the arm internally rotated but is decreased during external rotation is pain or clicking within the glenohumeral joint and may indicate a labral tear, or pain at the AC joint may indicate AC joint pathology. Positive slap lesion tests are confirmed with pain relief when the hand is supinated, and pain with cross-arm horizontal adduction is used to confirm an AC pathology. This is the acromioclavicular compression test. Patient is sitting with the arm hanging naturally at the side. Position of the examiner is standing on the uninvolved side, with the hands cupped over the anterior and posterior joint structures. The examiner then squeezes hands together, and pain at the AC joint or excursion of the clavicle of the acromion process is a positive test. Implications are damage to the AC ligament and possibly the coproclavicular ligament as well. This is the Apley scratch test. Subject is sitting, examiner stands next to subject. Action 1 is the subject is instructed to take one hand and touch the opposite shoulder. Repeat with the other hand to opposite side. Positive finding is asymmetrical results from side to side are positive. The inability to touch the opposite shoulder is indicative of a limited glenohumeral adduction, internal rotation, and horizontal flexion. Limits in scapular protraction may also produce asymmetrical results. Action 2. The subject is then instructed to place the arm overhead and reach behind the neck as if scratching the upper back. Repeat with the opposite side. Asymmetrical results from side to side are positive. Decreased motion on one side is indicative of a limited glenohumeral abduction and external rotation and scapular upward rotation and elevation. Action 3. The subject is then instructed to place the hand in the small of the back and reach upwards as far as possible. Repeat with the opposite side. Asymmetrical results from side to side are positive. Decreased motion on one side is indicative of limited glenohumeral adduction and internal rotation and scapular retraction and downward rotation. This is the Fegan test. Subject stands with the uninvolved arm abducted to 90 degrees, the elbow is extended and allowed to rest on the examiner's shoulder. The examiner then stands to the side of the subject and clasps his hands together around the upper and middle thirds of the humerus. The examiner then attempts to glide the humerus in an anterior-inferior direction. Positive finding is excessive gliding of the humerus as compared to the non-involved side may be indicative of anterior and or inferior glenohumeral instability. The grind test. The subject lies supine on the table with the shoulder abducted to 90 degrees and the elbow flexed 90 degrees. On the uninvolved side, the examiner grasps the subject elbow with one hand and the subject's proximal humerus with the other hand. The examiner then applies compression to the glenoid labrum while attempting to rotate the humeral head 360 degrees around the surface of the glenoid fossa.